everyone. We are delighted to welcome our first speakers, Dr. Andrew Morse, to present his recent work in a novel framework for quantifying immune dysregulations in critical illness. He is a pulmonary and critical care medicine instructor at Stanford. He grew up in Virginia, completing his bachelor's in neuroscience at the College of William Mary, followed by his MD at the University of Virginia, and then his residency and fellowship at Stanford. He works clinically in the ICU, and his research is co-mentored by Dr. Prabhat Khatris and Angela Rogas, focusing on using bioinformatics to develop better diagnostic and prognostic tools in the ICU. So welcome.
Oh, it's my pleasure. Thank you so much for having me. I'm just excited about the work and excited to spread the word about it. So really appreciate the invite. Let me go ahead and share my screen. How's that look?
Yeah.
Excellent. All righty. So thank you all for having me. I really appreciate the opportunity to present. As was mentioned, I'm Andrew Moore. I'm an ICU clinician and researcher, co-mentored by Angela Rogers and Pravesh Khatri. And our lab was super fortunate to have a series of papers published in Nature Medicine, and I'll be presenting that work here. So I have this slide up, but I'm realizing now that I should probably start with just pointing out what is sepsis. So sepsis is life-threatening organ failure defined by various metrics. Most recently been the SOFA score, which is just this metric of, how is your kidney working? How is your liver working? How is your heart working, et cetera. And that dysfunction is caused by what we suspect to be a host response to infection. I say suspect because it's actually really difficult to diagnose infection in clinic. And as a result of that, that's resulted in these very non-specific clinical syndromes rather than more sort of precision medicine approaches. And it's important to note that sepsis is common and deadly. It's the third leading cause of death globally and the single most expensive Medicare code in the US. And despite decades of experience, outcomes have remained largely unchanged. So you can see here on the right, sepsis mortality has essentially flatlined over the last 2 decades, despite how prevalent and how severe it is and how much money we put into trying to find solutions to it. And for this reason, we've done numerous clinical trials to try to improve outcomes. But as you can see, treatments are still largely limited to antibiotics and supportive care, IV fluids and vasoactive agents, which are essentially just agents to support your blood pressure, but don't actually have any effect on the immune response. There's been a lot of interest on trying sort of a variety of immune modulating therapies, but all of these trials have been negative. And this isn't for the lack of trying, right? So I brought up the fact that we looked at fluids earlier, and we're honestly still looking at fluids in the ICU because we don't have sort of any better therapies. But there have been, beyond just fluids, we've done many clinical trials in sepsis, and all of them have been negative. And honestly, it just doesn't make sense, right? So John Laffey and Brian Kavanaugh at the University of Toronto wrote a really nice op-ed in Lancet that basically pointed out that the math here just doesn't add up. If you flipped a coin and it came up tails 20 times in a row, you'd think that something has to be wrong with that coin. The chances of that are essentially zero. And if you look at things like oncology, the rate of positive clinical trials in oncology, where we have much more sort of precision medicine guided therapies, is something more along the lines of 50%. So it feels like we're really doing something wrong. And I think intrinsically, we all sort of know this in the clinic, that sepsis probably isn't just one disease. So hopefully you all have played with Play-Doh at some point, and you all know that eventually all Play-Doh turns to brown. It's just a matter of time. And I think sepsis and many other critical care conditions, particularly those that are syndromically defined, are just like this, in that there are probably multiple upstream conditions and biologic subphenotypes that eventually coalesce into a similar syndrome. And I think most experts would agree that it really is this lack of better subphenotyping or splitting that's hindering our progress in sepsis. The way that I liken to it is, oncology, you used to see a tumor and you just call it a cancer. And then we got a little bit more specific, and then we called it lung and colon cancer. And nowadays, you go into a oncologist's office, and they'll tell you it's an EGFR positive, KRAS negative lung adenocarcinoma, right? And so they've just gotten more and more specific in their sub-definitions in sort of this broader illness that they had previously. So one of the first key realizations in tackling this problem is really recognizing that patients with sepsis rarely die from their infection. Antibiotics do an incredibly good job at sterilizing infections as long as there isn't a source control issue. What patients die from is a dysregulated immune response. So I really, really like this figure, which essentially shows this kind of narrow homeostasis our immune system is in, and how imbalance in either direction can lead to worse outcomes. So either a hyperinflammatory state that leads to early death, or ongoing inflammation after resolution of your infection, or this lack of appropriate inflammation and too much anti-inflammatory can all lead to bad outcomes, sort of deviating from this homeostasis and causing us to not be able to resolve these patients' syndromes, even if the infection is solved. And so this really brings us to this key idea moving forward in trial design and honestly management of sepsis, which is outlined extremely well by Stansky and Wong in their review. Essentially, the central tenet is that sepsis is a heterogeneous condition and that this heterogeneity biases our clinical trials to the null. So we have to develop better biology-based subgrouping methods and target our interventions based on this biology. So here are the multiple steps here. The first we'll call sort of prognostic enrichment, in which we essentially just identify patients with sepsis who are at high risk. So these are patients who are going to have the outcome of interest that we're trying to prevent, such as mortality, and separate them from the patients who have a very low mortality risk, who are going to do totally fine regardless of what we do, right? These patients who are going to survive, we don't necessarily need to enroll them in clinical trials and place them at risk of harm. But these patients are the patients that we really want to act on. And then the next step is what we call predictive enrichment, where essentially we identify sort of the biologic mechanisms that are underlying their high risk signature and then treat those biologic mechanisms, sort of subgroup 1 versus subgroup 2. So again, very similar to the idea in cancer, in which you stage and grade the cancer to figure out how severe it is, and then you use mutations and other markers to decide which therapy to give them. So as I mentioned, there have been many attempts to make sense of this heterogeneity by identifying immune subphenotypes of sepsis patients who might be treatable. This is just a quick look at a few of the gene expression signatures that have been proposed in sepsis over the years. And you can see that different groups have identified anywhere between 2 and 4 endotypes in sepsis, with varying numbers of bad and good groups. But one of the key barriers to implementing these in practice is the lack of understanding of how these schemas and the various endotyping numbers relate to each other and how generalizable they are beyond the patient populations they were initially identified in. So for instance, these were identified predominantly in bacterial patients. This SOM score has 4 scores, but was identified predominantly in viral infections. This Wong endotype was actually identified in sort of pediatric subgroups. And so it's unclear, like, can you take the SOM score and apply it to bacteria? Can you take these SRS endotypes and apply them to viruses? Can you use a pediatric endotyping signature in adults? And what's their sort of overlap and what are their faults? And how do we sort of identify that better? And so this is where the Subspace Consortium came in. So the Subspace Consortium is an international group of sepsis investigators who agreed to share transcriptomic data with the goal to advance our understanding of sepsis biology and accelerate these translational findings to the clinic. And so here's an overview of the analysis plan. As you can see, our analyses were performed in parallel across 1,500 public samples and about 4,000 subspace samples. So here's the subspace dataset overview. So a total of, again, about 4,000 samples from the peripheral blood from 9 international groups, including pediatric and adult patients, as well as viral and bacterial sepsis. And the goal here really was to identify overlap between these molecular signatures, to identify consensus biology, rather than necessarily identifying patient-level clusters. So what we did is we applied all these different signatures that I showed in that slide before, and then showed through various clustering algorithms how these different endotypes and their endotype numbers uh, were similar or different from each other, identifying essentially consensus biologic endotypes. And here are the results. So I'll spare you some of the details for the sake of time, but in short, across 3 different unsupervised approaches, we identified 4 molecular clusters of scores, which essentially showed 2 detrimental clusters in this sort of orangish and purple color, and then 2 protective clusters in green and blue. The next thing I'll point out is that one of our collaborators identified this exact same thing. So we ended up collaborating with a group in Malta and Amsterdam, led by Brendan Scicluna, Tom Vanderpoel, and Julian Knight, looking at the intersection of subgroups. And what you can see is that they identified the exact same clusters using independent data sets and independent methods. So really showing that this is a robust finding, no matter exactly what cohorts you used, as well as what methods you used. And so this was published at the same time in the same Nature Medicine journal, just showing sort of the robustness of this biologic signature that we're finding in sepsis. All right, so we identified these clusters of scores. So the obvious next question is, where are they coming from? And so we next wanted to look closer at this biology. And to do this, we turned to single-cell RNA sequencing, integrating 4 sepsis data sets, including of the neutrophil compartment, which had 258 samples and over 600,000 cells to look at where these signatures were being expressed. And I will say big thanks to Hong Zhang, who's one of the scientists in the lab who really collated all this data and performed much of this analysis. So on the left is the network analysis, showing the identified cluster that we already talked about. And on the right is the results of the single-cell analysis. So on the y-axis, you can see the scores separated by the clusters that we defined. And then on the x-axis is cell type. Then you can see scaled scores with high scores in red and low scores in blue. And so I'll first turn to the most clear-cut groups. So this high-risk detrimental score in orange, all of which align, as you might expect, to the myeloid compartment, and in particular, these immature neutrophils. Then I'll point you to this protective cluster in blue, which lines really, really nicely with the lymphoid compartment, in particular T and NK cells. And then the somewhat more surprising subgroup, so this protective green subgroup, which is expressed in the myeloid compartment. You know, we usually think of neutrophils as these kind of dumb cells, but what this actually suggests is that there are protective subgroups of neutrophils and monocytes, which actually protect against severe illness. And then finally, this purple detrimental group. This has always been a bit of a puzzler for everyone. And you can kind of get a sense that it's kind of lower level activation of a mix of myeloid and lymphoid compartments. And we'll talk about sort of how we use this information in just a little bit. So all in all, we essentially have a mix of protective and detrimental myeloid and lymphoid subgroups. So this gave us an idea, which was to leverage this biologic understanding and single cell data to identify cell type specific scores to build a more flexible framework for quantifying immune dysregulation. So to do this, we evaluated all the genes across all of the scores we evaluated and picked only those genes that were specific to the myeloid or lymphoid cell types. We then split them into detrimental and protective genes and generated specific myeloid and lymphoid dysregulation scores, which can then give you a sense of how dysregulated the immune system is for a given context, allowing you to determine if you have a balanced response, compartmental cell type specific dysregulation, or more system-wide dysregulation. So one of the key questions you all might have is, why is this needed? And I think looking back at all the sepsis signatures is really illustrative of why this flexibility is required. So despite ostensibly asking the same question, all of the groups we evaluated came up with different numbers of endotypes. And this really comes down to the fact that forced clustering is method and context dependent. So for instance, an appropriate immune response to rhinovirus, or the common cold, may be totally inadequate to control MRSA bacteremia. And current endotyping schemas can't really deal with this issue to figure out what's an appropriate immune response to a given bacterial or viral burden. And then which axis you evaluate and how many subgroups you define will vary based on your clinical question and the treatment you're considering. For instance, medication that targets the lymphoid system, you just want to measure lymphoid dysregulation. Or one that targets neutrophils, you might want to measure myeloid dysregulation. Or you might just need two subgroups, a good and a bad subgroup, versus more specific four subgroups that we have aligned here, depending on sort of what you're trying to sort out. So as sort of mentioned, these clinical subgroups are really context dependent. And this is a really nice visualization of that idea. So this is looking at the framework we just discussed, and then with different colors, we're showing the mean and standard deviation across different severity levels, ranging from totally healthy individuals to non-severe infections, to severe infections in yellow, to fatal infections in this dark red. And what you can see is that the degree of dysregulation varies across the severity spectrum. That's not surprising, right? Like more severe infections are going to have more severe dysregulation. But what it does show you is that the case mix, how many non-severe infections versus severe infections you have, how many fatalities you have, are going to totally change sort of your ability to sort of discriminate these different subgroups. So case mix has a really, really important piece of what you identify. The other thing I'll say is that even depending on the type of infection that you have, can show different dysregulation. So for instance, these are all ICU level infections. So patients who required critical care and were incredibly sick. And what you can see is that whether you have a bacterial, a viral, or a non-infectious etiology of your critical illness will change kind of the degree of dysregulation you have on these axes. So you can imagine how if you had a mix of bacterial and viral infections and non-severe and severe infections, you'd identify different subgroups than if you had purely severe, purely bacterial infections. And I think that helps to explain this sort of context specificity and this sort of lack of generalizability of many of the existing subgrouping schemas leading up to this. Okay, so we had these scores and we had this framework. So then the question really became, can this framework be applied clinically? And so even though I railed against forced thresholding, we had to come up with something. You know, reviewers need a p-value. You need some graphs. And so one of the ways we wanted to look at this was just, can we use the healthy immune response to inform our understanding of dysregulation? And so in this case, we defined healthy controls as normal. And we calculated a mean and standard deviation for healthy controls and defined dysregulation across the entire cohort as a z-score greater than or equal to 1.65, correlating with essentially the 95th percentile of dysregulation in healthy controls. What you can see is that remarkably, despite being a really rough cutoff, this worked super well. So what you can see is that patients in this balanced quadrant right here in this bottom left essentially had a predominance of non-severe infections, which is in tan. And then as you sort of traveled up on either spectrum, you became more and more severe, requiring essentially ICU level of care or dying of your infection in this sort of top right quadrant. The other thing that I think is kind of appreciable here, and I think is really exciting, is that you have this kind of central clearing, and you have these patients who can go up in sort of either direction, becoming more myeloid or more lymphoid or more myeloid dysregulated and leading to severity without necessarily having both of these compartments dysregulated at the same time. So overall, quite exciting, a good sort of demonstration that this does work. Now, one of the other kind of interesting things we saw here is actually that this cell-specific dysregulation plays differential roles depending on the infectious etiology. So this is looking at the association with mortality across different infectious etiologies. So this is looking at lymphoid score in viral infections versus bacterial infections, and then myeloid score in viral infections versus bacterial infections. And what you can see, perhaps unsurprisingly, is that lymphoid score is much more associated with mortality in viral infections, whereas myeloid score is much more associated with mortality in bacterial infections. Now, this is really interesting, and again, kind of points to this context specificity, which is, if you remember, kind of likening back to this figure right here, remember, lymphoid score was more associated with mortality in these viral infections, but actually what you see is that bacterial infections have a higher lymphoid score. And so again, really points at the fact that you really need to take clinical context into account when you sort of stratify patients based on these immune dysregulation scores. And finally, this framework with continuous scores allows us to do that, to integrate dysregulation with the clinical context to make sense of what's going on. Okay, so then I think it's very exciting to see that this dysregulation is associated with worse outcomes, but obviously the holy grail in sepsis is to identify treatable traits in sepsis patients. So this was the next thing we wanted to explore, and fortunately within Subspace, we had two randomized controlled trials to explore this with. So the first trial was SAVEMORE, which is a randomized controlled trial of anakinra in COVID-19 patients. So on the left, you can see this bar plot of mortality on the y-axis, split up by lymphoid dysregulation on the x-axis, so dysregulated here on the right, and then treatment with placebo in gray and anakinra in gold. And what you can see here is that patients with elevated lymphoid dysregulation scores experience significant differential treatment effect. And this is a pretty profound effect. So on the right is actually the Kaplan-Meier for these dysregulated patients stratified by treatment. And what you can see is that there's a hazard ratio of 0.06 for survival in those patients treated with anakinra with dysregulation, as opposed to those who did not receive treatment for their dysregulation. And importantly, this difference was not seen based on myeloid dysregulation score. So I've held off on showing these results for brevity, but again suggests, as we mentioned before, that the flexibility of this framework and ability to look at different compartments of the immune system really is helpful. And then we then turned to VICTUS. So VICTUS was a clinical trial of vitamin C, thiamine, and hydrocortisone in high-risk sepsis patients. And so here you can see that exact same graph on the left. What you can see is that once again, patients with lymphoid dysregulation at baseline experienced a treatment benefit, this time to hydrocortisone, with a profound survival benefit very similar to that seen in anakinra. So this is across viral and bacterial infections across two different immune modulating therapies. We're able to show that this dysregulation that we're measuring is associated with heterogeneity of treatment response. Now, where the rubber really hits the road is, can this be implemented clinically? This is kind of where Pravesh's work over the last 10, 15 years really starts to hit the road. So Inflamatics, which is a spin-off company that Pravesh built about 9, 10 years ago, was recently FDA cleared for their Myrna device. This is a device that measures 29 mRNAs in about 30 minutes and then spits out 3 scores: likelihood of viral and bacterial infection, and then more importantly for our purposes, how severe this infection is. So essentially how likely that patient is to require ICU level of care and to die from their infection. And this is output as a score from 0 to 50 with 5 bands divided by 10. And all of the work that has led up to this was recently published in Nature Medicine as a companion piece to the ones that I've already shown, and just shows that this test, which can be run in 30 minutes, has the potential to totally change how we think about infections and sepsis. Now, importantly, we have to show that it does correlate with the biology that we already have looked at, and this is some unpublished data that's currently in revision. But what you can see is that when you compare high-def to Trivarity severity score, there was essentially a linear combination of myeloid and lymphoid dysregulation led to these Trivarity bands. So what you can see here is this low Trivarity band, very much associated with sort of balanced immune dysregulation. As you travel up in myeloid and lymphoid dysregulation, you travel up in your Trivarity band. So again, suggesting that this Trivarity score, which can be run in about 30 minutes, is capturing the same biology that we're capturing in sort of our immune dysregulation scores. And then finally, we have data showing that Trivarity score is also associated with differential treatment response. So again, across 2 ICU clinical trials, Trivarity was associated with differential response to steroids. You can see here on the left. So this is quite small, but essentially what I'm showing here is that in the VANISH cohort, which was septic shock, when you identify sort of low-risk individuals, patients who received steroids actually died more frequently. And then in these high-risk individuals by Trivarity score, in the VICTUS cohort, we again showed treatment response in patients with severe dysregulation. And then again, same thing with Save More here, which was that anakinra COVID-19 clinical trial. What you can see here is that patients with a high trivarity score, again, showed treatment benefit from anakinra. So in conclusion, I hopefully have convinced you all that sort of all host response signatures that were evaluated in this study follow along essentially two axes defined by myeloid and lymphoid immune dysregulation, which allowed for the creation of a unified consensus immune dysregulation framework. And this flexible framework allows for context-dependent decisions for identifying patients with severe infections and other forms of non-infectious critical illness, and then reducing heterogeneity of treatment effect with hope that in the very near term, we can start to translate this immediately to clinic with things like the Myrna device. I'd like to acknowledge my mentors, Angela Roger and Pravesh Khatri, my co-fellows and lab members, and honestly mentors who helped me just like get through this project as a clinician with very little computational knowledge. Our subspace collaborators who shared their data and the patients who contributed their data, and then the Stanford Pulmonary T32 and K-12 programs for their support of me. I have this bioarchive up here, but it's now on Nature Medicine, so I would direct you to that instead of the bioarchive.